Hi, everybody. I'm just going to wait for everybody to come in. Um, Hi, everybody. We're here in another VMR for the CP Solvers. Voy a hablarles un poquito en español. Yo soy María, soy de Guatemala. Soy una estudiante de medicina y me encanta tenerlos a todos aquí. Everybody, I think, knows a little bit about VMR, but it's a great place in a community where we discuss a case in real time with everybody, and we have a lot of fun. We make mistakes. We accept that we don't know everything, and we keep learning a lot. So very excited to see everybody here.
Hello, everyone. My name is Rafael, and I'm a medical student here from Brazil. And sou Rafael, sou estudante de medicina também, assim como a Chiara e a Maria. So here today we have a special VMR, which is dedicated for a global community, non-native English members. And we try to celebrate different cultures, different languages, and we try to highlight those different voices from all around the globe. And we really encourage you to join us wherever you are. And it's a very special place for us, and I hope that it's a very special place for you too.
Hi friends, so my name is Chiara and I'm a medical student from Peru. I will introduce myself also in Spanish. Mi nombre es Chiara, soy estudiante de medicina de Perú y estoy encantada de verlos a ustedes otra vez. I just will explain the format for today's VMR, which also will be recorded for a podcast. So the idea is that you all volunteers, some of you will have a case to present, an amazing case. I know you always have an amazing case to present. And we all in the chat have comments, questions, ideas, problem representations, or maybe differential diagnosis, and we will pick many comments from you and encourage you to say them out loud so we can all participate and learn from each other in many languages and from many places from the world.
Thank you all. Ahla wa sahla. Ana ismi Rabia, which means good morning, or actually no, which means hello. My name is Rabia. It's very hard to say my name in English with the harsh H at the end. And I am a clinician educator based in San Francisco. And I'm originally from a little town outside Beirut, Lebanon called Zahle. It's hidden in beautiful mountains. And that's where I spent most of my childhood, only to move and spend a lot of time in Lahore, Pakistan, jahan Urdu bolte hain, where we speak Urdu. And so you can imagine that I spent most of my life abroad, and to be hanging out with a global community from all across the world is a dream come true. I always told myself that I would somehow go back and serve the communities that I grew up outside the US. And with COVID, it brought that gift a little bit early with a virtual morning report, which we do every day, as Maria explained. And to be able to have that dream not only come true, but really a dream beyond many dreams of having people from all across the world hang out and talk medicine is a delight. And the truth is, we don't just talk medicine. We talk medicine, we talk life, and we talk many other things. And in order to join us, all you really have to do is to sign up on the link that we have below. It's totally 1000% free. If I could afford it, I would pay you to join. But unfortunately, living in San Francisco, despite making attending salary, is very expensive. Anyway, without further ado, we want to jump right into it. And last week, usually, to be honest, we actually have a call for a case presenter spontaneously, and somebody volunteers right then and there. But last week, not only were we promised a case, we were promised a guitar performance from a dear friend in Chile. Hernan, do you want to unmute, introduce yourself, and tell us more about your life outside medicine first, please?
Yes, thank you all. I'm very glad to be here. This is a really amazing space. And my name is Hernan. I'm from Chile, from a city that is called Concepcion, that is at the south of Chile. And I am an internal medicine doctor, an internist. and I work at Las Higueras Hospital. I'm also a teacher at the Concepcion's University. And I like very much to play guitar and sing.
So, are you ready?
Oh,
Are you ready? You promised a
I am
live performance.
I am ready for the case.
Okay, so no guitar performance today, huh?
No guitar performance.
Okay, but you know what? No, no, I'm not gonna let this slide. I'm not gonna let this slide. What's your favorite song? Favorite song?
Ooh.
No, don't tell me. Sing it to us. Come on. Only just like 10 seconds. That's all. That's all.
I love Cat Stevens.
Ooh. All right, let's hear it. Let's hear it. Come on, you got this.
I will have to bring the guitar then. So
Okay, all right. Okay, I'm gonna let it slide. I'm gonna let it slide only because I know you have a fantastic case for us, and but really I'm gonna hold you to it at some point in the near future. Can you before you jump into the case, Hernan, do you mind just telling us about your journey? And oh my God, yes! Hey, it's here now. It's here now. Only a minute. Only a minute.
this is my girlfriend that brings me the guitar.
Yes.
She betrayed me.
Oh no, no, no. She didn't betray you. Not at all. All right, I'm gonna mute myself. Go.
It's not time to make a change. Just relax and take it easy. You're still young, that's your fault. There's so much you have to know. A fine girl, now settle down. If you want, you can marry. Okay.
Holy smokes, yo! Y'all get goosebumps. That was unreal. Wow. Hey, listen. I think that
This is very embarrassing.
no, no. Listen.
Yeah.
If you need a career, an alternate career outside medicine, I think it's just gonna happen right now.
Okay.
Thank you. Okay, so without further ado, I'll let you jump into the case, and as always, I'd encourage everyone in the chat to. I'm going to ask you to share your thoughts in real time. Type them in the chat, and the whole point is to show people who are listening how incredible you all are. So please, please, please type and reflect away in the chat, and I will call on everyone to try to get their voice heard. Before you start talking about the medicine, please unmute yourself, introduce yourself. Tell us a little bit about where you're from and the language that you speak, and tell us then about the medicine. Okay? All right, Hernan, take it away.
Okay, thank you. Well, this is a 45-year-old woman who presents to the emergency department with fever.
Terrific. Why don't you tell us a little bit more, Hernan?
Okay. Early in the month, she was evaluated for fever and sore throat that was treated with antibiotics for 5 days. 2 weeks later, the symptoms persisted and she was evaluated again. She was febrile with myalgias and arthralgias and had started with a rash. She was diagnosed with an allergy reaction and was discharged with returning precautions.
This is a perfect place to stop, Hernan. Thank you so much. I see some incredible comments coming from the chat. Kushal was teaching us how to say fever in a couple of different languages. Kushal, do you want to unmute? Tell us who you are and both what you just said in the chat, please.
Hey everyone, I'm Kushal. I'm the hospitalist based in North Carolina. So fever is said bukhar in Hindi and Urdu, and in Gujarati it's called tav.
Incredible. Thank you so much. And Kanu, you were sharing a mnemonic for it. Tell us more what you were saying.
So it's a mnemonic that I learned from the CP solvers itself. It's I made with the capital I, as Reza likes to say it. Capital I stands for the infection, which is the most common thing. And apart from that, it is malignancy, autoimmune drugs, and endocrinopathy that in the descending order itself.
Absolutely brilliant. Thank you so much, Connor. Before you go, tell us where you're calling from. Tell us your name and where you're calling from.
Hi everyone, so I'm Kanu and I recently graduated my medical school from India, and I'm calling from India right now, and I'm going to pursue my IM residency this coming July in US.
Incredible. Thank you so much for coming. Congratulations, Connor. Amanda, hello. Question for you.
Hi, everyone.
Oh, introduce yourself, please.
Hi, my name is Amanda. I'm a medical student from Brazil, and today I am at the farm.
Ooh, you're at the farm. What's that behind you?
It's some trees. Just
Oh, it looks absolutely gorgeous. Hey, Amanda, what are you thinking so far with this case?
repeat, please.
What are your thoughts so far with this case?
So it's a woman with fever and antibiotic using antibiotic and non-responsible. I think may to be ABV, like Rafael and Tiago say, and it's only this.
I love it.
Let's see what has.
Incredible. I absolutely love that. Brilliant. Thank you so much. You said Tiago, and Tiago has an incredible point in the chat. Tiago, can you unmute yourself and tell us more? And introduce yourself, please, of course.
So, hi, everybody. I'm a physician in Brazil, and I'm always happy being here. So I try to join here as much as possible. When I'm not working, I'm here. That's the reality. So I'm an endocrinologist, but I worked with internal medicine for a long time. I'm not working right now with it, but I can remember from that time that I saw many patients complaining of sore throat, and then it's very common to treat them with antibiotics. So in Brazil, just to say a random fact, we don't have strep test as often as you have in the US. So there are places in which you can have strep tests, but not here. In Brazil, there are not so many places. So many people, they get antibiotics. But then when they come back, it's very important to remind that it's not common for strep to be resistant to antibiotics. Maybe azithromycin. You should not treat them with azithromycin because it can be resistant, but amoxicillin, no. And then if the person does not get better using amoxicillin, you have to think about differential diagnosis. And a rash after using antibiotics, it reminds me EBV, but Escuchal is the king here. And he said not just EBV, but also all mono-like syndrome. So I'll just repeat what he said. And so thinking about differential diagnosis, people put here Lemierre disease. It's not common to present this way, but we should think about. And actually, I've seen a patient with this complaint, and the final diagnosis was a Steele disease. So that just to keep it in mind, that it's another rare possibility. Yeah.
Incredible. Thank you so much, Tiago. Mario, you had a couple of excellent points about lymphocytosis. Do you want to introduce yourself and tell us more about that?
Yes. Hi, my name is Mario. I'm a six-year medical student from Lima, Peru. And to establish the diagnosis of infectious mononucleosis, one of the pearls is to see lymphocytosis with atypical predominance. And if you have more than 50% of lymphocytosis of all white blood cell counts, and do you add that, and if you add to that more than 10% of atypicals, the positive likelihood ratio for infectious mono is, I remember, was around 54. So it's it changes your pretest probability amazingly.
Brilliant. I think that's absolutely key. And often, actually, there's a couple of VMR cases where the diagnosis end up being mono, and that is the big pivot point for sure. And maybe I'll summarize where we're at. I think this is to summarize the case, this is a subacute syndrome that features inflammation, with fever being the most specific sign of inflammation. And the center of gravity of that inflammation is fairly diffuse. Why do I say that? We have pharyngitis, we have myalgias, arthritis, and rash. And so the case is not coalescing to a very specific area. But it seems that the focus in our conversation is to use the pharyngitis as the guiding clue. And that, I think, drives the point that while pharyngitis has a broad DDX, it certainly is more specific than myalgias, arthralgias, and a rash. The truth is that if we gain clarity on the rash, we might actually change our minds, because the rash is vasculitic or evocative of bullous diseases or nodules. It might have some specificity to it, but right now the best thing to work with is pharyngitis. And pharyngitis is one of those few itises that spans the entire eye-made mnemonic. Infections that cause pharyngitis are usually non-specific viral infections, but the three specific viral infections to entertain are the mono-like viruses, influenza, and measles. Those are the three viruses you have to think about. And mono-like, as Tiago said, expands to EBV, CMV, HIV, toxo, etc. As was mentioned in the chat by Mario, and not only do you have to think about pyogenic bacteria like group A strep, but you have to think about sexually transmitted infections as causes of pharyngitis too, and to recognize that rarely granulomatous infections like TB, paracocci can also go to the pharynx. I will tell you a Lebanese delicacy and a Lebanese unique infection. It's called halzoun. It is actually having fasciola, a parasitic disease, cause pharyngitis, because we tend to have this in a specific kind of cheese in Lebanon. So it's a very unique disease that's very geographically restricted, and you should look it up. It's spelled Halzoun. And Maria doesn't care because it sounds delicious. But that's the infection. There are malignancies like lymphoma and leukemia that cause pharyngitis because of Waldeyer's ring, a lymphotropic area that's in the back of the throat. There are autoimmune diseases like Still's disease, as Tiago mentioned. Kawasaki's disease can also cause pharyngitis. Malignancies, we talked about autoimmune diseases. Drugs is the D, and that's where SJS/TEN, drug-induced hypersensitivity syndrome, all cause pharyngitis. And finally, E, endocrinopathy. And in I'm looking right at Tiago right now, and I'm remembering a case of de Quervain's thyroiditis, subacute granulomatous thyroiditis, where the presenting complaint was really bad sore throat. So the entire spectrum of eye-made, infection, malignancy, autoimmune, drug, and endocrinopathy, all of them are at play here. And so we have to cast a very wide net, but as Kanu told us, the eye is capital. And that's what our focus is on, eye, and we'll see where the rest of the data takes us. Okay, all right, back to you, Hernan.
Okay, 1 week later, the symptoms has not resolved, and she presents at our emergency department in our hospital. She refers subjective fever sensation on a daily basis, no sore throat at this point, mild articular pain in the knees and wrists, and a rash in the trunk and extremities. Do you want me to go further?
Yeah, why don't you round up the HPI and just give us the medical history, all the way until the allergies.
Okay. She has no past medical history of significance. She has no use of any drugs and over-the-counter, and she has a negative travel history. She has no allergy history also.
Incredible, Hernan. And no other medications apart from the antibiotic that she got, correct?
Correct, and the antibiotic was amoxicillin.
Amoxicillin. Terrific. Thank you so much. This is a lot of information here and so many comments streaming through the chat. I want to say that I love that our approach is not only just most common, but also most morbid. And Valeria has some excellent points about morbidity. So do you want to unmute yourself, introduce yourself, and go from there? I'm not sure if you're still there, Valeria. Please unmute yourself if you are. Oh no, we lost. It literally just dropped off right now. That's okay. We'll ask her to come back and comment on on that specific spectrum. But Nilayan is adding an additional thought. So Nilayan, do you want to unmute yourself? Tell us who you are and share your thought, please.
Hello, everyone. I'm Nilayan. I'm a fourth year medical student from Delhi, India. And
unfortunately, your audio is really choppy. I would turn your video off. Maybe.
Specifically, joints, my particular involvement. Oh, okay. Hello.
Are you there?
Ravi?
Yeah, it's better now. Go for it. What were you saying? Tell us, introduce yourself.
Here I'm finally from dramatic fever. We so be possible even though we
unfortunately, your audio is I'm really sorry, your audio is really choppy. I will tell you all about Nilan. Nilan is a medical student from India who has recently joined the VMR community and has some brilliant thoughts. And he added the possibility of rheumatic fever, which bridges the infection and autoimmunity and is a great reminder that though we don't see much rheumatic fever in the United States, you have to think about it in a case of pharyngitis and arthritis. I think that's absolutely brilliant. Thank you, Nilan. I'm sorry about your audio. Valeria, are you here to tell us about your thought about morbid causes of pharyngitis? Please unmute yourself and introduce yourself to the VMR crowd.
Yes, hello everyone. Sorry, my Wi-Fi got just when you asked me before. Yes, I am a fifth year medical student from Peru, and I was just thinking about things that could be life-threatening for the patient in the case of acute pharyngitis. The possibility that this could be an abscess that was not detected at first, like a retropharyngeal abscess or a peritonsillar abscess. And also the possibility of diphtheria, just because in Peru we had an outbreak last year because of poor vaccination. And so this could, possibility of contacts or pharyngeal membrane on physical exam, something that I will be looking to rule out this possibility that could quickly progress to maybe, I think, cardiac complications for the patient and could result in her unfortunately dying.
Absolutely brilliant. Thank you so much. I really, really can't add anything to that. Thank you so much for sharing it. I saw that, where was it? Sorry. I saw that, completely missed it. 1 second, folks. There's some, it's just absolutely brilliant stuff coming in from the chat. Yeah, Rafael, you were asking about what the rash might be from. Do you want to unmute yourself, introduce yourself, and tell us more?
Hi, everyone. I'm Rafael. I'm a medical student from Brazil. I'm fourth year. And when I saw myalgia and arthralgia and rash, I thought about cutaneous porphyria or some kind of lupus. And I don't know, these two diseases are commonly associated with sun exposure. So I asked on chat if it has something to do with sun exposure.
Brilliant. I think that's a fantastic question. Trying to understand what is driving the rash. And our hypotheses so far are, is it drug induced? Is it spontaneous and part of the syndrome? Or is it as a result of specific exposure? Beautiful. Kano, you have a story about porphyria. You want to share it real quick?
So I read in med school that werewolves actually could not actually be a myth. They could actually be a real story. that because of the intense moonlight, that rashes could worsen, and they were actually porphyria patients that had their skin changed and they looked like werewolves.
No way, that's incredible. That is amazing. I love it so much. Valeria, not to call on you again, but I think that's a great thought. So tell us what your hypothesis about reactive arthritis.
Yes, I was just thinking it because the patient had an infectious event that could result in maybe, and then articular pain that, I mean, could be part of a prodrome of an infectious organism, but it could also be part of a reactive arthritis, and also maybe looking for other characteristics like an uveitis or other ocular compromise. And also the rash, I know that reactive arthritis could manifest with a lot of different types of rashes. So the pattern and the type of cutaneous manifestation is really important also.
Brilliant. I think that's the point that we should start to really expand. That is a great, great catch, is to start to think what can cause pharyngitis and arthritis. But I think there's a great comment that just came from Igor. Igor, do you want to unmute yourself, introduce yourself, and tell us that this question that you're asking in the chat so everyone can ponder it too? Oh, I think your audio is not coming through, my friend. I'm not sure why.
Are you listening to me now?
Yeah, I can hear you now. Yeah.
Okay, great. My name is Igor. I'm a second-year resident in internal medicine in São Paulo, Brazil.
Incredible.
I asked if the rash is pruriginous. I like to have a little more information about the rash because I think that it can lead us to different diagnoses. I want to know if the rash may be associated from the drug because in the first admission of the patient, she had the sore throat, but she didn't have any rash. 2 weeks later, the rash appeared, and if it was after the use of antibiotics. One of the options you already said is EBV. There can appear a rash after amoxicillin use, but it can be another hypersensibility reaction from drugs. You talk about SGS, can be DRESS. So I did want to know if the rash is pruriginous because in some of these diseases, the rash isn't, but in another are. For example, virosis that comes from mosquitoes.
Yeah.
It's really frequent here in Brazil.
Yeah.
And for example, in my mind, arthritis, rash, fever,
yeah.
It could be something like chikungunya or Zika disease. In chikungunya, the arthritis is more frequent than Zika, but in Zika, the rash is pruriginous. And that was more or less my line of rationale.
Amazing. All I can do is clap. That was brilliant. Thank you so much for sharing it. Really appreciate it. I'm going to share some reflections and really honing in on what we're reflecting on now with Igor and Valeria. But I will ask my dear friends, Rafa and Chiara. So Rafa, if you can have a problem representation in Portuguese and Chiara a problem representation in Spanish after I'm done, I would be very, very, very grateful. So what we learn now, really, I think, is just the fact that Hernan is telling us this case is refractory. The symptoms keep going, the fever's there. The pharyngitis has gotten better, but I think we have to think about this as a pharyngitis plus arthritis plus rash. And again, because of what Igor just said, we don't have enough information about the rash quite yet to use it as a dominant feature, but it's pretty suggestive that this is a pharyngitis plus arthritis syndrome. And I think the things to prioritize when you have a combination of pharyngitis and arthritis, from an infection perspective, Neisseria gonorrhea has to be an important consideration. Neisseria has a strong propensity to go to the joints and often originates in the pharynx. Nilayan reminded us from the get-go that rheumatic fever, a bridge between infection and autoimmunity, is another thing to consider. Within autoimmunity itself, Still's disease, as Tiago alluded to from the get-go, has pharyngitis plus arthritis and also causes a rash. The same is true of Kawasaki's disease, and the same is true of all the spondyloarthropathies, so psoriatic arthritis and reactive arthritis are the two that really feature the combination of being triggered by a viral reaction, but also featuring pharyngitis, arthritis, and a rash. So where are we now? I think we have a lot more digging and a lot more understanding to do, but it's hard not to prioritize infection and autoimmunity, with the primary infection to never miss as a cause of pharyngitis and arthritis is Neisseria, with infection plus autoimmunity centering on rheumatic fever, and then primary autoimmune diseases, I'd say the focus is on Still's, Kawasaki's, and reactive arthritis. But that is a hypothesis that is very loose, because when we don't have definitive information on the rash and the joint issues to gain more clarity. But those would be where the spotlight is currently shining, though you wouldn't be surprised if the rash and the arthritis are actually very different and our spotlight moves to a whole different world. But maybe we can summarize the case so far. With Rafa, can you tell us how you would summarize this in Portuguese? And then Chiara in Spanish.
Sure. Então, uma paciente feminina de 45 anos, que foi recentemente tratada por suspeita de faringite bacteriana e se apresenta com febre persistente, dor de garganta, mialgia, artralgia e rash.
All right, Chiara, thank you so much, Rafa. How would you summarize this in Spanish?
And in Spanish, I will say, paciente femenino de mediana edad sin antecedentes de importancia ingresa por fiebre persistente asociada a faringitis, artralgias y reciente rash por antibióticos.
Brilliant. All right, Hernan, back to you. Give us some more data, please.
Okay. Do you want me to give more details about the rash?
Yeah, well, why don't you give us the exam and the labs?
Okay. Let's go to the physical exam. She appears to be acutely ill with mild dehydration. She has a blood pressure of 128/70. She has a heart rate of 117. She has a temperature of 39.5 Celsius. And the SpO2 is normal on room air, 99%. The physical exam is really with no significant abnormalities, but the skin exam is with a macular erythema that is non-pruritic, more pronounced at the belt line. And the articular exam shows no synovitis, no sign of synovitis.
Perfect. And would you like to say or add any more information?
Yeah, why don't you give us the labs, Hernan?
Okay. The white blood cells were 20.70. The hemoglobin was 13. And the platelets were 389.
Wow, that's a high white count. Do you have the differential?
Yes, it was 88% of neutrophils. 7% lymphocytes and 4% monocytes.
Terrific. Okay, why don't we actually stop here for a moment. Hans, can you unmute yourself, introduce yourself, and tell us what you just said about where this is taking you?
Yes, when I saw that 88% neutrophils, my thought was drifted away from dengue fever more towards something bacterial. So that could point a little bit more towards the rheumatic fever that we mentioned before, or post-streptococcal glomerulonephritis, something like this. That might still everything open.
Good.
I don't know.
Yeah, no. One, I just absolutely love that. I think that you ending by saying that you don't have clarity is perfect, because there's no way. But it's hard not to say neutrophilia points to a more bacterial process. Beautiful. And before we go, can you introduce yourself and tell us where you're calling from?
Yes, I'm presently visiting my mom, and that's in Germany, southern Germany, close to Switzerland.
Incredible. Can you tell us how you would say a high white count in German? Do you know?
Oh, because I studied in the States and I don't know.
That's okay. No worries at all. I'm just curious. Incredible. Thank you so much.
I would say viele weiße Blutkörperchen.
Ooh, that sounds so beautiful. I just absolutely love how German sounds. Thank you so much, Hans. It's so good.
Thank you.
Drew, my friend, what do you mean the inflammation's not funky?
Hi everyone, I'm Drew, veteran maven of the Clinical Problem Solvers VMR from the US. And there's this whole schema on the Clinical Problem Solvers site that talks a little bit about inflammation that is not neutrophilic. And whenever you think about non-neutrophilic inflammation, or funky inflammation as we have termed it, there is a whole set of differentials that we go down. But as Hans had mentioned, this is neutrophil predominant inflammation. So we're tending to think more about some of the typical bacterial causes of infection rather than something that would be, say, a granulomatous infection like tuberculosis, or a parasitic infection, or a fungal infection that might lead to eosinophilia.
So well said. I can't believe you're able to teach funky inflammation in a minute. That was brilliant. Thank you so much, Drew, my VMR veteran. Okay, folks, for those of you listening on the podcast, I'm sorry that you won't be able to see this, but another plug to join us live, where we share some of the schemas that haven't yet been published, and I'm going to do that right now with neutrophilia, because I think Drew said it's not funky, and Hans said focused on the neutrophilia. So here we go. So I'm going to take over the screen for a second, folks, and tell you that neutrophilia really does represent an infection in the vast majority of cases. And that infection can be pyogenic bacterial infections, like Hans was saying, group A strep, or other infections, not necessarily bacterial, like molds or granulomatous infections. If you move beyond infection, there's a second tier to make contact with. And because Tiago's here, I'll start with endocrinopathy and Cushing's disease, especially the ectopic version can have a high white count. Malignancies can do it too, and they are solid much more than liquid. And autoimmune diseases. It's just so happens that not all autoimmune diseases cause a high white count. And for example, lupus typically causes a leukopenia. And the subset that tend to cause the high white count really are vasculitis, Still's disease, IBD, and rarely rheumatoid arthritis. So that should be the focus. Is this an infection? Is this a seronegative autoimmune disease like vasculitis or Still's? Is this a malignancy? And is this Cushing's? There's really no data to suggest it's Cushing's at all, so let's move that away. Pharyngitis is usually on account of a liquid tumor. So we talked about lymphoma and Wall-Dyer's ring. So liquid tumor plus neutrophilic leukocytosis is very unusual. So I think cancer is unlikely because the combination of pharyngitis, which would suggest a liquid tumor, is less compatible with a high white count, which argues against a liquid tumor. And autoimmune diseases, if you look at that list of autoimmune diseases, there's a single diagnosis that stands out, and that's Still's disease. And I think this case has really come down to our usual dilemma. Is Hans' instinct correct? Do we have to dig deeper and deeper and deeper for an infection that we're missing? Or do we start to pivot towards an autoimmune disease? And an autoimmune disease that features pharyngitis, arthritis, and a rash the spotlight is starting to move towards Still's disease, which is important because the morbidity of untreated Still's disease is high. What happens in patients with Still's disease is they can get pretty destructive arthritis if you don't think about it or treat it soon enough. So here we are in the age-old dilemma. Are we going to give this person antibiotics because of an infection, or do we have to pivot towards an autoimmune disease? And here the priority of autoimmunity should be on Still's disease. So Hernan, why don't you take us to as far as you can with all the data before the answer is revealed, then we'll have the chat reflect.
Okay, at this point, she was evaluated for an internal medicine team and was, the rash history was taken into consideration again, and she mentioned that the rash was triggered by the fever. And it was on the physical examination, it was a very salmon color rash. So the rest of the labs were renal function was normal, but she had a sodium of 129. The RCP was 8.1, and the urine analysis was normal. And she had an autoimmune panel solicited, and she was an anti-nuclear antibody of 1/320, and she had a ferritin of over 2,000. She was also studied with a CT scan that shows no relevant abnormalities.
Ooh, Hernan, what an absolutely brilliant case. Thank you so much for bringing it to us here. There's a lot to reflect on for sure. I'm going to ask my dear, dear friend Maria, the trifecta of the CP solvers, who has not said anything yet on the VMR. Do you want to unmute yourself and maybe summarize the case in your mind in English? Maria, where are you at?
Yes, I'm at a point where I'm very confused because we have a lot of symptoms that started with fever and sore throat, and then we added myalgias, arthralgias, and a rash with leukocytosis not funky enough, because it seems very funky, but not funky enough of blood cells to call it that. And then with a possibility of making it like an autoimmune disease because of the autoimmune panel and the non-responsiveness to antibiotics. And that's where I'm at.
Brilliant. And where are you thinking in terms of individual? If you had to prioritize like 3 or 4 diagnoses, which one are you playing around with in your mind?
So I start with autoimmune, which a lot of things that I don't understand. So you mentioned Stills. Yep. I think that would be like number 1, but I don't know too much about it, but I do know it's like one of a diagnosis where you have to exclude a lot of things, including malignancy and infections. So we're not there yet to call it Stills because we haven't excluded a lot of other things. And then maybe HLH with the fever and the, what other thing does HLH have? I only know fever and like high ferritin. So that's the 2 things. That's my 2 diagnoses so far.
I love it. I think using the ferritin is very, very important. Kiara, can I ask you to share your thoughts in Spanish? Where are you at? I won't understand anything, so you can say, well, you can literally bash me and say how bad I am if you want. That works.
I can lie to you. Well, in Spanish. Actualmente, me viene a la mente, al ser una paciente femenino, tiene mayor probabilidad de ser una enfermedad autoinmune. Por lo tanto, Eso concuerda también con el panel autoinmune, por lo tanto también me lleva a pensar que puede ser enfermedad de Stills o artritis psoriásica o algún tipo de artritis reactiva, pero también ANA positivo es como yo lo tomo como un screening para el lupus. Quizás no sea un lupus inducido por antibióticos, pero quizás sea lupus, un debut de lupus de la misma paciente. Eso es lo que estoy ahorita.
Thank you so much, Kiara. Rafa, you know what's coming next. What are your thoughts in Portuguese?
Ok, so em português. Eu concordo com o que a Chiara disse. Eu acredito que, por ser uma paciente feminina, aumenta a maior probabilidade de ter uma doença autoimune. E a gente entra naquele dilema que o Rabi sempre ensina a gente, que tentar distinguir sempre a doença autoimune da doença infecciosa, porque o tratamento de uma poderia piorar a condição da outra, né? Então, se eu imunizei meu paciente devido a uma doença, e ele, na verdade, tem uma doença infecciosa, estaria prejudicando mais do que ajudando. É daí.
Oh, so good. So good. Hey, folks, for those of you who are listening who aren't here, when we start talking about the medicine, I don't want you to forget the community. And I'm going to reflect and close this out and pass the mic to Ernan in a moment. But I wanted to shout out really everyone who has participated today, with a special thanks to Hernan for bringing a case, Amanda for sharing her thoughts, Drew for sharing his thoughts, Hans for jumping in, Igor for jumping in, Kanu for jumping in, Kushal for jumping in, Mario, and really the whole crowd. Nilan, who unfortunately had some audio difficulties, was a big feature of our conversations as always. Raphael too, and of course Valeria for her thoughts, and she just shared her PR. And I think it's perfect to hand the mic to Valeria to share her PR before I share my final thoughts and we transition to Hernan. So Valeria, tell us your problem representation, which will be a nice segue to share our concluding thoughts.
Yes, okay, so it is in Quechua, which is a native language from Peru, from the Andes. And well, it's a Sipalja, Tawa Watayuj, Tawa Chunka, Pishha Watayuj Kachkan, Shaira Antibiotokowan, Hampirhan, Kawaiwan, Rash, Pitpuna, Chalwan, Mujukuna, Nanachkan. And well, it's basically your PR translated to Quechua. So
amazing. You're going to make my heart melt. But before it does, I'm going to share my thoughts. To bring this back to the medicine, we have a young woman who had a resolving episode of pharyngitis, which was followed by a rash, arthritis, and a neutrophilic pleocytosis. And we also found that her ferritin is through the roof and greater than 2,000, and I think that gives us a pivot. The differential diagnosis of hyperferritinemia is non-specific. It's non-specific because in critically ill patients, many of them have a high ferritin. So I think the specificity of the ferritin is augmented in an otherwise stable patient. Now, I'm not going to make the argument that this patient is not sick, but she's certainly hemodynamically stable. And the stability of her offers more clarity as to what the cause of ferritin might be, and it boils down to three things: Still's disease, hemophagocytic lymphohistiocytosis, or hemochromatosis. In a young woman, age 45, who is likely still premenopausal, hemochromatosis is unlikely. Hemophagocytic lymphohistiocytosis is a fascinating syndrome, which is really a funky kind of inflammation that features cytopenias. And it is the lack of cytopenias here that makes that diagnosis very unlikely. And so it's hard to move away from a case of Still's disease here, and this is a classic illness script for Still's disease, as a pharyngitic syndrome that begins and then resolves to leave a signature on the white count with a neutrophilic pleocytosis, a rash that comes and goes with the fever, and joint symptoms. The other features of Still's disease, one of which is a prominent thing we have to contend with in a moment. Other prominent feature of Still's disease, in addition to a resolving pharyngitis, to a rash, to arthritis, is serositis. So patients get pleuritis, pericarditis, and very rarely abdominal serositis. Another thing that is usually present is the elevation of liver enzymes. So most patients have elevation in their AST or ALT. So what do we do with the big thing that is glaring at us, and that is the ANA? most patients with Still's disease are classified as seronegative, that they have a negative ANA. And here, unfortunately, that's going to be one thing that we'll have to contend with and learn from Hernan from. Because if you remove the ANA, this patient has a very classic presentation of Still's disease. If you put it back in, you have a diagnostic dilemma and maybe a CP Solvers virtual morning report case. So with that, I will pass the mic to my dear friend Hernan to sing us out with some medicine thoughts before we pass the mic to Rafa to do some teaching.
Okay, this was a very interesting case. This was a pre-COVID case. And at this point, the infectious causes were all negative. That include blood cultures, infectious endocarditis, all the viral panels. And the rash was very compatible with Still's disease. That was our work hypothesis. But the anti-nuclear antibody was really a confoundant, also with the history of antibiotics that was a confounder also at beginning. And with all the study, there is a 10% of Still's disease that presents with low titers of anti-nuclear antibodies. And so with all other causes excluded, we confirm the Still's disease and we start on steroids, and the patient was resolved the symptoms. And she was typified as an adult Still's disease. And we even did a biopsy of the medulla, and it was with hypercellularity that is also compatible with Still's disease.
Hernan, that was an absolutely brilliant case. Thank you so much for presenting it and for teaching us about the nuances of Still's disease. I also want to shout out that the folks who are listening to this on the podcast, you heard Hernan pause and slow down, and that's because he's a master case presenter at keeping up with the scribe Chiara and Rafa in real time. So thank you for being not only incredibly intellectually intelligent by bringing us this case, but your emotional intelligence through your voice, your singing, and how you presented this case is through the roof. My dear friend from Chile, thank you so much for joining us. All right, we'll conclude with our final teaching points from Rafa, and thank you all again for joining us, but let's nerd out one more time. Rafa, take it away.
So first, thank you, Hernan, for the case. Really, really interesting. We learned so much from this global community, and it's always a pleasure to be here. So we had a patient with fever and sore throat, and it's not CP Solvers if you don't think about the immune mnemonic, which stands for infection, malignancy, autoimmune drugs, and endocrinopathy, trying to encompass all the etiologies leading to fever. And then we talked a little bit about antibiotic refractory therapy. There could be many causes, including wrong dose, or wrong antibiotic, wrong bug. What if there was a EBV infection at play? But also non-infectious cause or a different SARS, for example, osteo, endocarditis, and abscess. And then we saw that this patient had fever and myalgias, but there are many etiologies that could lead to fever and myalgias. So we have to try to focus on things that are have less etiologies, for example, pharyngitis. But actually pharyngitis englobes the whole IMID spectrum. So we talked also about the monolag syndrome, which is characterized by the fever, hepatosplenomegaly, pharyngitis, and lymphadenopathy. Also, many bugs could lead to monolag syndrome like CMV, EBV, HIV, toxoplasmosis, but also influenza, measles, and STIs. And we can see lymphocytosis with our typical lymphocytes on the blood smear, and there this pearl that was shared with us, the moxilin immunonucleosis can result in a macular papular rash. And then Robbie taught us about rash in general. It could be a specific exposure or part of the clinical syndrome or a side effect of the treatment, for example, a drug leading to hypersensitivity reaction. And then we tried to combine the arthralgia, the myalgia, the fever, and the rash, especially in a patient from Latin America. We have to think about dengue, Zika, and chikungunya. And then we tried to talk a little bit about the concept about the funky inflammation, which is non-neutrophilic predominant inflammation. For example, lymphocytosis could be a sign of neoplasia like CML. And then, but we saw on the hemogram that that this patient has actually neutrophilic inflammation and could have many causes like infection, autoimmune like vasculitis, Still's disease, drug, malignancy, and also endocrine cause like Cushing and other like alcoholic hepatitis. And then, which was the final diagnosis, we talked about Still's disease, which is an inflammatory disorder marked by fever, arthritis, and rash, and also resolving pharyngitis. Lymphadenopathy and hepatosplenomegaly can also be seen. And rarely, this disease can lead to renal dysfunction with proteinuria and also neurologic involvement such as seizures. And then Ravi reminded that we have to treat as soon as possible because it can lead to destructive pharyngitis. So thank you, everyone. It was such a special event for us, and I hope everyone enjoyed it.